I can't use this because it doesn't work. I'm Dr. Greenberg. This is Dr. Hamilton, my colleague with the Brigham and Women's Hospital. And as I indicated in my talk yesterday, our group has seen over 80 patients with mast cell-related disorders. So what we want to do now is make sure that we address as many questions as we can. So keep your questions focused, and we'll try to keep our answers to 1 minute. Okay? So anything related to symptoms, diagnosis, fundamentals of treatment, medications, with regard to GI problems and mast cell disease is on the table. So, start.
What would be the primary cluster of symptoms that you folks would see that would suggest you should move in that direction?
Yesterday I said there are 8 features of mast cell activation syndrome. 80% of the patients have flushing, belly pain, and dermatographis. 80%. Over 50% have the other symptoms, which are headache, sweating, mental fog, can't concentrate, diarrhea, alcohol intolerance, and can't take a hot shower. So anybody that I see that has belly pain and flushes gets all 8 questions asked.
Okay.
And if they have the triad, the 3 that I've just said, I will then go ahead and get the requisite laboratory studies. The baseline laboratory studies are serum tryptase, 24-hour urine for N-methylhistamine, and at the same urine specimen, they will measure prostaglandins. If any of those are elevated, it's abnormal. Now, what I said yesterday was that...
Excuse me, I'm sorry to cut you off, but they're trying to record each of the sessions. That's why I put a microphone. It's not going to play over the PA.
Okay. It's recording.
But it's just going right to a recorder. So if you can, if
Okay.
it's going to be recorded, you don't have to, but they are trying to
Okay,
record
all right.
the session.
So, the basic laboratory studies then are the urine, the serum tryptase, the urine histamine, the urine prostaglandin. If somebody has a lot of flushing and their prostaglandins are elevated, that's a clue that we need to consider putting them on aspirin, because aspirin inhibits the production of the prostaglandins that cause the flushing and the vasodilatation. Other symptoms are treated with specific medications depending on what the symptom is. But the first order of business is to get them on get a patient on an H1 and H2 blocker, and then depending on the symptoms, either Singulair or Cromolyn, and those are the 4 basic drugs that we use. Don't be reticent now. Yes.
I have some concerns. I'm taking protonics because I have reflux and the abdominal symptoms, and I'm just concerned what damage that might be doing to me or my bone.
Question is, this young lady is on protonics as well as H2 blockers. PPIs are safe. They've been used in 50 million people. They do have side effects. There is some evidence that in older patients it may lead to osteopenia or reduction in bone density. There is some evidence that it can lead to C. difficile, which is a form of colitis. The other caveat is that if you're on a PPI like protonics and you stop the drug, or one of your doctors stops the drug abruptly, your stomach will rebound and you will have a lot of acid. And so therefore, if you're going to come off the medication, it should be done under supervision where there's a very slow taper of the medicine over 2 to 3 months. Many of our mast cell patients have reflux symptoms that are not controlled by an H2 blocker like ranitidine, famotidine, nizatidine, and they have to be on a PPI. If you have esophagitis, so you've had an endoscopy and you have evidence that your esophagus is inflamed, you will be on a PPI until the year 2046. 46. Well, I think if you're on Prilosec, you should also be on a calcium supplement. You should have your vitamin D level checked. If your vitamin D level is low, you need to be on a preparation that has both vitamin D and calcium in it. and your doctor should then check your vitamin D level to see if the supplement that you're getting is bringing your vitamin D level up to snuff. If the issue is that if the PPI is controlling your symptoms and you're on a twice-a-day dosage, you should then try to get down to a once-a-day dosage by knocking off the evening dose every other day for a month. If you're on a once-a-day dosage, you're not having any symptoms, you might cautiously, with the advice of your physician,
Yes, you are my physician.
as Pogo has said, we have met the enemy and it is us. No, I know that there are about 40 or 50 of my patients here, and please forgive me if I didn't immediately recognize. I recognized you, but I didn't recognize you.
I was in there for years. But you're great by email. Yes.
Okay. All right. Thank you for reminding me to be awake. Do you have a question?
She has another question.
I always have questions. You mentioned about irritable bowel. Well, one follow-up though to the Prilosec. What about dietary concerns? If someone's trying to get off a proton, any recommendations? Because you had your list of foods.
Well, if you're trying to get off a proton pump inhibitor, it should be done under the guidance of a physician. And there should be a specific taper schedule, and they may wish to substitute an H2RA in a bigger dosage. If you're already taking ranitidine, 150 milligrams twice a day, you can try that. But talk to me about it. Questions?
I have a question. How many of your mast cell activation syndrome patients are on elemental formulas?
Or what?
Or on elemental formulas and are not eating foods?
It's an interesting question. To my knowledge, none of them are on elemental formulas. As far as gluten sensitivity is concerned, that's a real issue. Now, classically, gluten sensitivity is associated with what is called SPRU, celiac disease. And those patients have typical abnormalities, the most common of which is an iron deficiency anemia. But they also have trouble when they ingest gluten products, so they get belly pain, diarrhea, discomfort, and what have you. We now know that you can have gluten sensitivity and not have SPRU. So people, my daughter, for example, does not have SPRU. She can't eat bread, she can't eat matzah, she can't eat pizza, she can't eat pastry, she can't eat any gluten-containing products. And if she happens to be in a restaurant and orders something that's cooked in a pot that's cooked gluten material, she'll get symptoms. So I tell people I have a dietary log. It's a sheet of paper, and it's in our book called 4 Weeks to Healthy Digestion. But basically, it's a 1-week log. It says date, time, symptom, food eaten. You aren't smart enough to remember, even though you're very smart, what you had for dinner last Wednesday night. But I tell patients that you can't remember if you have a bad day. And this applies to mast cell patients also. If you have a day where you have unaccountable symptoms, even though you're on full doses of medicine, think about what you might have eaten, because there are about 15 foods that make your bowels run, and there's 10 foods that slow them down. And it could be that you had a runner that day that started your bowels up. So I'm not smart enough to ask you, nor is your doctor, all the different foods that can cause symptoms. I just gave you a dozen of the most common ones. So I tell people that if they notice that wheat products, bread, pastry, pizza, cause symptoms, then they ought to keep a very careful log. And many patients then will go to a gluten-free diet to see if they feel better. And if they feel better, then I tell them, challenge yourself. Saturday night, you're home, have a pizza, have a toasted cheese sandwich. If they do that and they get symptoms, then they have additional evidence to support the notion that they stay off gluten-containing products. So gluten sensitivity is very common. So is celiac disease. 1/3 of our patients with mast cell disorders have concurrent irritable bowel, related in large part to what they eat, A few of them are gluten sensitive.
And not just concurrent irritable bowel, they could have concurrent other issues as well, like lactose intolerance, for instance, food allergies. So, you know, we think of all these things all the time that, and test for them if we can.
Probably a stupid question, but if you have someone who only has, say, 3 or 4 of that list of symptoms, over a period of time, do they tend to develop additional symptoms?
Good question. The question is whether people have only 3 or 4 of the big 9 or big 8. What will happen with time? Unpredictable. Some people, after we sensitize them to some of these questions, and they're now looking about these particular symptoms, or it might be things they haven't thought about. For example, does your skin turn beet red when you take a hot shower, so you don't take a hot shower? That's a symptom that's important. So in general, if they have a mast cell activation syndrome and they're on treatment, 70 to 80% of the patients either have no symptoms or are markedly improved. 20% require more treatment. There are a few, in spite of our best efforts to control their symptoms with conventional doses of medications, we're not entirely successful.
Well, I don't know if we've seen the progression of symptoms that you're speaking of. You know, generally a patient presents to us with a set of symptoms, and it's generally the way it stays. We haven't seen, you know, progression.
Well, that's because we've interrupted, we like to think we've interrupted their disease by giving them medicines that are designed to stabilize their mast cell population.
If anything, they're better. Less symptoms.
Yes?
My wife was diagnosed 8 weeks ago with aggressive mastocytosis, and she's been given a medicine called Gluten.
Yeah.
It's caused her to have massive diarrhea, and her physician has given her prescribed Lomatil. And Lomatil cures it for a couple of days, but makes her so constipated she goes off of it, and then she has diarrhea again.
Right.
And I thought perhaps there ought to be some way of improving that.
Well, that's a very good question. The question was, in a patient that has systemic mastocytosis is on Gleevec, one of the side effects is diarrhea. If you give people enough Imodium, you'll make sure they don't have a bowel movement for a week. You don't want that. You may want to talk to her doctor. Don't do this on my recommendation. But we have found that one of the best drugs to treat watery diarrhea in people who have myeloma, have leukemia, have mast cell disease is called Cholestipol, Cholestipol. And what that does is, this is particularly effective if you ask a patient, is your stool ever green or orange or bright yellow? If it's those colors, it means they have too much bile salt, which is making their bowel run off and cause diarrhea. If that is the case, they are going to be much more likely to respond to this particular medicine. I use this. I hardly ever use any Imodium or Lomotil, because what it does is, here's a patient who's have diarrhea, you give them Lomotil, it paralyzes their bowel, clamps down. What happens when the effect of the medicine wears off? They have escape. So then you take more medicine, and you get into a vicious cycle where you may not move your bowels for a couple days. So don't do this on my accord. Talk to her physician and ask him to consider the possibility of using a bile salt binding drug called Cholestipol. We use a lot of that. It's a very effective drug, and we have no hesitation in using it. The caveat is, if you use that medicine, they have to take it before they go to bed at night, because the drug can interfere with the absorption of several other medicines. You want to make sure all their other medicines are long been taken by 9 o'clock in the evening, so they can take this medicine at nighttime.
One other question. My wife has always had an excellent appetite. She's a marvelous cook, loves to eat, and now she has no appetite. her doctor prescribed
Megace?
is that the one that's got progesterone in it?
No.
The one he advised sounded like
Well, if it's Megace, that's an appropriate drug. That's appropriate. If it's Megace, that's an appropriate medication. Appropriate. Appropriate. Okay. MEGACE.
that sounds like
The question is dosage. Is it 40 milligrams? Well, talk to her doctor and make sure that everything that we say here is for your edification, but you don't have any license to go ahead and ask for that without working with your doctor.
she didn't want to take it because it's progesterone.
Does Megace have progesterone in it? I don't know the answer to the question. Yes.
So just recently I was diagnosed with cutaneous mastocytosis.
With what?
Cutaneous mastocytosis.
But for a few years now I've had a constant sore throat, just kind of all the time, and I get nauseous and stomach cramping a lot. And I'm just wondering if that's, you think, something that, a food that I've been eating, or if it's related, or...
You haven't given me enough information. Do you have skin lesions of cutaneous mastocytosis?
But they're not, like I don't get rashes.
Okay. How many of the other 8 symptoms do you have? Do you get diarrhea when you menstruate? Okay. Do you have typical reflux symptoms where you get heartburn if you eat certain foods? If you drink coffee, chocolate, orange juice, tomato juice, do you get heartburn? Okay. But you have a sore throat? Okay. The sore throat could be due to reflux. A lot of people have reflux, do not get typical heartburn, but they get a sore throat. They may cough a lot. Do you clear your throat a lot? Like that? That's another symptom.
Worse in the morning when you first wake up?
No, and I was prescribed something for that
Ranitidine, famotidine, Pepsid, omeprazole.
it didn't seem to help.
Well, omeprazole may not help reflux symptoms that involve the throat. What you need to do is to have a session with your doctor and tell him in very clear terms, I want to know whether my cutaneous mastocytosis is responsible for this, or is this concurrent, unrelated reflux? And the people that have reflux but don't get heartburn get cough, clearing of the throat, occasional hoarseness, and a sore throat. So the question then is, when do you get this symptom? Okay. Well, has anybody looked at your throat? And what did they find?
They said it was red and swollen, but not that bad. It wasn't anything really bad.
Well, 2/3 of the people that have a sore throat, it's not due to reflux. It can be due to postnasal drip or chronic sinusitis. So those are other things your doctor has to think about.
But just because you have cutaneous disease doesn't mean your mast cells aren't giving mediators out, and so we're getting symptoms from mast cells. So people with cutaneous mastocytosis do have a lot of these symptoms, reflux, heartburn, nausea, all the things, symptoms we've been talking about. So some of the symptoms might be mast cell related.
Several years ago, I was trying to figure out what was wrong with me, and so I had the, what did you call it, the corporate, whatever.
Endoscopy?
Well, I had lots of stuff, and that was one of them, and a colonoscopy, and they, I think that one of the presenters had said that if you have, if the hospital still has my skin biopsies that they have, should I pursue getting them stained to see if I actually have
If this was done how many years ago?
maybe 10?
How many?
10?
10. If they still have the slides at the hospital, you can ask them to do specific stains for mast cells. Now, that's only going to help you if there are a ton of them, a lot of them, more than 30 in any field. Dr. Hornick, my colleague, has done a study to show that everybody here, if you had a biopsy, would have some mast cells in your tissues. The question is how many and whether they're in clusters and things like that. So it probably would be reasonable to do that on the offbeat chance that it might show a very large number of mast cells. You have other mast cell problems?
Most of mine are GI related.
Okay, all right. You're welcome.
The other option is to get an updated endoscopy more now, or more recent, and then we can do the studies right away.
I was just wondering
if
it would be good to compare from 10 years ago to today, or does it matter?
Yeah.
Probably doesn't matter. It's the number that count now.
Yeah, exactly.
Quick question. I've always been told you shouldn't eat anything 3 hours prior to going to bed. Is that true?
Depends if you have symptoms. Some people work 9 to 9. They come home have dinner with their wife at 10 o'clock, go to bed at 11, and they do it with impunity. On the other hand, some people finish dinner at 8. They eat something at 9, and they lie down to go to bed at 10:30, and they have reflux at 2 o'clock in the morning. This is symptom-driven. If you have nighttime symptoms, then the common sense test is avoid lying down for 2 to 3 hours after you've eaten your dinner. I don't say to everybody do that because some people like a snack. If they like a snack and can handle it, great. I'm very flexible.
About the biopsies, because I did have endoscopy and colonoscopy with the stain, and I did have more than 50 mast cells in my colon. Could that explain some more symptoms that I have?
Yes. Patients that have a mast cell-related disorder that have a lot of mast cells in the colon, most of the time they're in the right colon near the appendix or in the left mid part of the belly right here. So they can then get more urgent bowel movements and have cramps before a bowel movement. The answer to your question is yes. With more than 50 mast cells in your colon, that's abnormal and can contribute to your symptoms. And they may not go away even with appropriate mast cell treatment, which is why you also have to be very aware of what you eat, when you eat, how you eat, what are the medicines you're taking, et cetera, et cetera. But I haven't seen you for a couple of years.
No, you haven't. But you've seen my daughter.
But that means you're well.
But we should review that because we should look at the morphology of the mast cells, and we have other special stains as well to make sure that it's not like a mastocytosis case.
I would like to do that.
We should review those.
Could I ask her? I'm sorry, I don't mean just one other thing. My daughter has irritable bowel syndrome. She is being seen by you very regularly. But what about that in families and all? And we've talked about a relationship between irritable bowel and systemic mastocytosis. That doesn't necessarily mean she will develop disease,
No.
right?
Irritable bowel is extremely common.
The irritable bowel afflicts 20% of the population in this country, 90% of whom are women, and 90% of those 90% are premenopausal. Your daughter's in good company. I can't hear you.
Well, the routine endoscopy and biopsy diagnose mast cell disorder or any specific stain?
We go with the symptoms that I told you in those 3 laboratory tests. We ordinarily do not do endoscopy and biopsies unless there's a reason to do that. One of the reasons being a failure to respond to all the appropriate anti-mast cell treatments, or if there's anything in the history that suggests there may be another issue. If and they're over 40 years of age and has never been worked up, then we would suggest that for the sake of completeness, they have an upper endoscopy.
What percentage of patients with functional abdominal disorder has mast cell disorder?
Don't know. It depends. Here's the issue. Many doctors today, and I'm going to be critical, don't spend enough time with patients to take a history They have a complaint, they're sent for a CT scan, a whole bunch of blood tests. If they show something, you call the patient back in. If they don't show anything, the patient's given a diagnosis of irritable bowel and told to do this or that. So we find that that's a very difficult statistic to get. What I can tell you is that at the Brigham Hospital, we see about 2,000 patients a year with bowel complaints. If you look at all the patients that see Dr. Hamilton, Dr. Greenberger, Dr. Castells, Dr. Aiken, there might be 200 that have mast cell disease. So if you put 200 over 2,000, you get about a 1% incidence of mast cell related disorders in the global population of people that have diarrhea.
So, in your opinion, the endoscopy and biopsy not necessarily is crucial to diagnose mast cell disorder?
No, no. What's crucial is a history, a physical examination, demonstration of dermatographism about the tryptase, the urine histamine, and the urine prostaglandin. We will do all that first, assess the response to treatment, unless there's something they tell us that is a clue that there might be something else going on.
Repeat the three tests again.
The three tests are serum tryptase, a 24-hour urine sample for N-methylhistamine, and urine for prostaglandin D2 or F.
We think we just published a paper looking at mast cell activation syndrome, and there's a whole spectrum of mast cell disorders. But mast cell activation syndrome, all the biopsies we looked at, and all the patients that had endoscopies and colonoscopies, the mast cells were all completely normal number, normal morphology, normal shape. So yeah, so that's why if it's just mast cell activation syndrome, it's actually important to look for the mast cells. If we're worried about mastocytosis, that's when we would do the special stain for the mast cells.
Now, let me share with you something that's in our paper. The average patient we see as a new patient has been to 3 doctors, has had symptoms for 5 years, and has had an EGD and a colon and a CT scan and an MRI, etc., 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 because they're looking for something that's not there. So what we try to do is minimize, that's a $3,000 set of tests, and if they're not indicated, we're not going to do them. Hi, Beverly. Another one of my patients. Are you going to try to get back to Western Massachusetts tonight?
No, my husband said stay.
Power's out.
What?
Power's out in the Berkshires.
Get out. Already? Serious? Power's out.
That's the rumor that was circulating around here and said, sit tight, don't go anyplace.
Exactly.
Can I ask another question? What are foods that tend to be better with some patients with the mast cell activation syndrome?
I didn't hear the first part of the question.
Okay, on your mast cell activation syndrome patients, are there certain foods that tend to do better than others?
That's an interesting question, and it hasn't been studied. The thrust of the question is, if you have mast cell activation syndrome and you happen to eat a lot of histamine-containing foods, will it make your symptoms worse? Is that the question?
Well, are there some foods that are better for you than others?
Well, the dietitians can tell you which foods are rich in histamine and which are not. I have not, in most instances, seen it necessary to put a patient on a low histamine diet. A lot depends on the symptoms. For example, if they're having bloating and distension and things like that, I will say avoid eating big meals. Avoid fatty foods because they slow the stomach down. Avoid greasy foods, French fried potatoes, pork chops, what have you. But I can't answer your question because I don't know at my fingertips the histamine content of various foods.
I guess the question follow-up would be is, do you tend to eat more fruits
I don't know.
Okay, I'm just asking.
Yeah.
I said, are there any other diseases that you know of that follow the 8 criteria for mastocytosis?
No. Irritable bowel patients have belly pain and diarrhea and alteration of bowel habits. They don't have flushing, they don't have dermatographism, they don't have alcohol intolerance, they don't have mental fog, they don't have headaches and sweating. So those 8, if they have all 8 of those, in my mind, that's a strong suspicion they have a mast cell related problem. It's the flushing and the rubbing of the skin. Now, 4% of the U.S. population has dermatographism. You rub their skin, it turns red. But of that group, very few have mastocytosis.
We're about halfway through our session, so if anybody would like to switch to another group or take advantage of another opportunity to speak to different physicians, you should think about moving now.
You're right, and there are a lot of diseases that will have 3 or 4 of those symptoms, but there's really just mast cell disease that has all of that.
What?
Once you hit 7, you should really be thinking mast cell.
If you start out with the big 3, flushing, belly pain, and dermatographism, the chances are 80% that you have a mast cell problem. Those big 3.
So it's very likely.
Very likely. The chances are 78.65837%.
When you were talking about before, if someone wants to kind of like test themselves to see if they're, like not eat gluten for a while to see if they feel better, how long do you recommend someone not to eat that food?
Gluten foods?
Yeah, like if you're testing to see if you feel better without eating.
Well, you've got to do it for at least 1 or 2 weeks because if you do it once or twice, it doesn't count.
Right. So like at least.
You've got to give yourself a consistent challenge.
I think I can keep listening, but I would be interested to know if there's anything special that
What we've emphasized in this discussion is the classic symptoms. What?
Maybe repeat the question.
Yeah, anything special that they should be testing for during a colonoscopy in a masto patient?
Ordinarily, colonoscopy is not the first test we do in a patient we think has mastocytosis. We catalog the 8 or 9 symptoms we've talked about, the physical findings, and we will check certain laboratory studies such as a urine for N-methylhistamine and prostaglandins in the blood. We'll also find out whether they have multiple allergies or food sensitivities and go from there. But the patients we see have already had 3 endoscopies, 3 colonoscopies, 3 of everything. We usually see no reason to have to repeat any of that.
It's also important for them to rule out other diseases again, like an inflammatory bowel disease and the routine standard things that every gastroenterologist would be able to do.
There are no special tests, anything that they should be looking for as far as mast cells in the.
If you suspect that somebody has a mast cell disease and they're going to get an endoscopic procedure for either a related or unrelated symptom like severe esophagitis and heartburn, then we will ask the endoscopist to get tissue and we'll look at for mast cells. But as I pointed out yesterday, you have to have a very large number of mast cells and tissue for that to be significant. If I were to biopsy everybody around the table and do mast cell stains on all of you, you'd all have mast cells. But you wouldn't have 50. Patients. Patients. Now, very loyal of you to come. Did you tell them that I paid you $50 to show up?
No.
If he had an esophageal biopsy and has 80 mast cells, that's much too many, anything over 50. If you had esophagitis, you're also looking for eosinophils, because a lot of people have what is called eosinophilic esophagitis, and the major symptom there is that food sticks in their throat. So in a patient that tells me my food is sticking over here, that problem comes up front and center.
And with the mast cells, what would you do?
Well, as I've said many times yesterday, today, and the day before, if you have somebody that has a suspected mast cell disorder, you catalog all 8 or 9 key symptoms, and you know what they are. Okay. I would then do a physical exam and see whether I feel anything abnormal. I would then order routine laboratory studies, and I would order special mast cell studies. That's openers. What I would do after that would depend on what that showed. The 80 mast cells per high power field in the setting of all those symptoms says, yeah, you have mast cell disease.
And I'd probably have another pathologist look at it as well. So oftentimes in cases like this, we have 2 different pathologists weigh in to interpret, not just one opinion.
We were going to just repeat it all.
Pardon?
Is that a wise course? Because we were just going to repeat it all.
You could.
Well,
treat the esophagitis maybe, and then repeat it.
It depends on what else is in the esophagitis. If they have Barrett's, for example, that's a whole different story. Very different.
I have a question. Hi.
This is recording, so that's
I'll repeat the question.
Oh, okay. I have stomach mastocytosis. I have essential thrombocythemia, and I really don't have many symptoms except the GI. I've been tested for celiac. I don't have it. Lactose puts me anaphylaxis. I avoid it. But it seems like I can only eat red meat, chicken, like the plain foods. And it makes my life miserable.
Well, have you been tested for intolerance to those other foods? You've had extensive... Well, have you seen an allergist or immunologist for that? Okay.
I always hematologist.
Well, the question here is this young woman has said she has thrombocythemia and mastocytosis. That diagnosis was made on a biopsy of your stomach?
No.
How was it made?
It was bone marrow biopsy, and then I tested positive for the JAK2 mutation.
Okay.
My
All right.
platelets
All
are
right. Okay.
600,000.
Well, if you are having specific food intolerances, the important question is to be sure that it's an intolerance without allergy or it's an intolerance with allergy, and for that you need to see an allergist who will test you to see which category you fall into. The bottom line, however, may be the same, and that is if food A gives you trouble, then you got a problem. If you're going to eat food A, you're going to have symptoms. So then you would have to see, and you may already have done this, you have to see an expert nutritionist who's going to be able to go through all the permutations of your particular problem and suggest foods that you can handle.
There's 2 different ways to get gastrointestinal symptoms and mastocytosis. One is just a number of mast cells in your colon or stomach might be so much that you're having problems with absorption of it. Yeah, so I mean, it may be because of your gastrointestinal symptoms, it might be worth doing that just to get an idea of how many.
But even if I had it, what can I do about it?
Are you talking about mast cell disease?
And then the other big
No,
reason.
with mast cells in the colon and maybe the GI tract. 40% in the bone marrow.
Well, the point of the matter is that anti-mast cell medicines stabilize mast cells so they don't continue to produce the noxious hormones and products that give you symptoms. So that's why the vast majority of patients who have a mast cell-related problem and are on a sufficient amount of medicine have control of their symptoms.
I'm on Gastrocom, Prilosec, Zyrtec, Pepcid, and Doxepin.
Cromolyn?
Yeah.
Singular?
Never tried Singular because I don't feel
I can't tell you what to try because I don't know your story. But what you need to do is to be sure that you see somebody, either a gastrointestinal specialist or an allergist immunologist who knows about not only mast cell problems but GI problems. It may be that you have 2 sets of problems. One is GI and one is mast cell related. You know that you have a mast cell problem because you have mast cells in your bone marrow. Whether that accounts for all of your symptoms is an open question, because somebody would have to sit down with you and spend 45 minutes and ask you 50, 60 questions and then carefully examine you and then review all the information that is available on you.
My hematologist, he even has me take Zyrtec like 20 minutes before I eat, because I used to flush a lot when I ate. And he said it was the art of chewing or something that put the strain and triggered. I mean,
Well, I'm not going to comment about what Dr. X told patient Y, but I will say that in most of our patients who have a mast cell disorder, they're on a set regimen. I then have a chance to interview them and see how effective that regimen has been. And it's usually an H1 blocker twice a day, an H2 blocker twice a day, cromolyn 4 times a day, aspirin if they're flushing, and other things. So I don't want to get into the issue of finding out what Dr. X does. Okay, because it's very bad for doctors to be judgmental about other doctors without data.
But the importance of a food diary as well. We talked about that with some other people.
That's how I caught the dairy after.
Well, yeah, there you go. So it's helpful with that, and you might find that you're going to pick up other things as well. And it's helpful for the physician to see that. You can bring it into them and show them what you're eating, what your diet consists of.
Very little. Thanks.
I get pain, not too frequently, right at the bottom of the breastbone, a squeezing pain.
Okay. When you get that, does it feel like you can't swallow?
No, it's usually.
Okay. You may be having spasm there. What you need to do is talk to your doctor, tell them about that symptom. You don't have any heart disease. That's been excluded. You've had appropriate tests. Had a stress test? Okay. That's the first order of business when you have chest pain. Make sure it's not heart. Then I would talk to him and say, could I be having esophageal spasm? If the answer to that question, if he says is yes, your next question is there a test that I can undergo to see if I have esophageal spasm? The answer to that question is yes. Gastroenterologists do that all the time. What?
You say, well, what was the first step in that?
Make sure you don't have a heart problem. If they're having pain here and it feels like there's something inside squeezing down on their feeding tube, it may be that's in spasm. If that is substantiated by appropriate tests, there's a very simple treatment for that. It's called magic mouthwash. Lidocaine, Benadryl, Mylanta. Take 2 tablespoons. Symptom will dissipate in 10 minutes. Now that's assuming the patient's been examined, everything's been done, there's no heart problem, and the doctor listening to the patient has been able to get all the information he or she needs. If I keep coming back to the fact that I'm unhappy with today's doctors, it's because I am unhappy with today's doctors.
What are you trying to say?
What? I'm one of them. Not him. But the bottom line here is that when I was training 52 years ago, all we had was a history, a physical exam, and some basic laboratory studies, so we learned to talk to patients. What's happened in today's express line medicine is you have 15 minutes with your doctor. He doesn't even have time to go over all your medicines with you. And then you want to get your questions answered, and he'll send you to the nurse practitioner. This particular disorder is one that requires doctors to be attentive, to ask all the questions, and to make sure that they have the information base they need to deal with you. Is that right, Norma? Norma's one of my patients. She had been, how many doctors over years? 4 or 5 or 6?
32 doctors. I don't know how many surgeries.
32 doctors.
32 doctors.
Over 5 or 6 years.
Over 7 years. 6
Over
years.
7 years.
6 years. 7 years. And I just thought,
Well, part of this is we're trying to go around the country in a lot of these conferences and things and educate physicians, practitioners about this, because it's not well known about. So if people can ask the right questions to their patients, I mean, hopefully we're going to pick this up a lot more. Right. Yeah.
His paper that came out in the Journal of Allergy Immunology is a landmark paper. It's the Brigham Initial Experience. Oh, we'll get you a copy. That should probably go and be reprinted and sent to every member of the Mastocytosis Society. Yeah. We can do that, can't we?
We can put it on the website, yeah.
If you put that on the website, which you can do, it's perfectly legitimate to do that. But if you read that article, you got it all. Everything we've talked about is in that paper. Well, I'm interested as to whether we should talk to Mariana. We should talk to our allergy colleagues to see if their national meeting, there could be a possibility of a presentation on this particular issue at the national meeting attended to by 3,000 allergists.
Is that the Quad AI or the ACAAI?
I think it's the American Academy of Allergy and Clinical Immunology.
Next weekend. It's here in Boston.
Do you have a booth there?
Yes. I'm working it. I work with pediatric.
Okay, so what you ought to do is email me.
Okay.
We have this publication online.
Okay.
We'll send you a copy. You can make 100 copies and have it at the booth.
Sure, we'd be happy.
And just say, we need to have you know about mast cell disease.
Right. And usually when we attend, I've been working the ACAAI for 6 or 7 years now. We now get doctors that seek us out at these conferences. They find out we have a booth there, and they come to us to get the information because, of course, there's so little information.
You need 100 copies of the art. If you,
yeah, we can do that.
You have my email address?
No, but I will. Okay. Yeah.
Because my secretary sends out dozens of these.
Yeah, that's not a problem. It's next weekend, so right here in Boston.
You're right in time.
Yes, right here in Boston.
Norma.
I'm probably going to see you soon. I was doing really well. I was like the miracle child of this. And then this summer, I got Lyme disease really severely. And I have not seemed to come back from it. And recently, my gastro pain is incredible, and I have nausea all the time. And I don't know if
Okay, are you on Tygan? Are you going to see me on next week? Or? Okay. Well, you ought to call me. There are things I need to talk to you about in detail. What happened to you is not unusual, and that is if a mast cell patient gets another illness, a B stage. I just made that up. There's no such thing. It can set your mast cell back, and so the question then is whether you need to increase specific medicines or not. If you're using more pain medicine, that's also not so good.
Well, I'm on methadone, so
right.
we've got me off the other stuff. But I'm still on a very low dose because we're still working
okay,
out,
all right.
The nausea is what's driving me insane.
You need to email me because there's an anti-nausea medicine that's very good called Tygan, which will stop your nausea.
Okay.
Tigan.
Right, I will be.
I will call. I need to give you the benefit of talking to you in more detail. Even though I know you very well, but I'm not going to violate my own rules, which is I will not prescribe that until I talk to you.
Right.
Are you followed by an infectious disease specialist as well, or?
Well, I just actually talked to Dr. Castells, and because I also have a high ANA, and she just told me to make an appointment with her. I told her I was seeing you, and she said to make an appointment.
Is that Dr. Castells?
Yeah.
Yeah, see her.
So she because I've got high ANA.
Dr. Hamilton and I share lots of patients with Dr. Castells, Dr. Aiken. It's a very good team, and we consult each other liberally, particularly if there are allergy or immunology issues that surface.
Right. I also have, the last time I got really bad like this, they found out that they did a liver function test, and that was abnormal, and they ended up doing an ERCP, and my common bile duct was blocked, and they had to do a sphincterectomy. I have no idea what's up, why that ever happened to me. And then 9 months later,
well, gallbladder disease is common.
They took that out.
After the gallbladder comes out, you can get scarring down there, narrow the duct. That's common, and it's probably not related to your mast cell problem. Probably not.
Mine was, however.
What?
I went to the emergency room with mine totally closed off.
Mine was
They
too.
took a biopsy of it. My mast cells were extremely high.
They never
Now, they already knew I had mast cells.
See, they didn't know I had mast cell when this happened.
Unless the mast cells have caused the tissue to scar down. Unlikely, but there's a test that you can do to see that, called MRCP.
I've had like 3 of those.
Have you had one recently?
No. I have another
Well,
one.
you and I will talk.
Okay. My
More.
buddy, Dr. Carlack, left.
We're still in touch with him, though. We can find Dr.
He
Carlack.
knows me really
Yeah, yeah.
well. And I was almost thinking if I have to do
Carlack.
that.
Oh, yeah.
Dr. Carlack is the one that did that, and he left me. But he gave me his email, but I think if we
That was a
all-
couple years ago, right?
Yeah.
Yeah.
Right. We're on to something.
You've been very quiet. Any questions?
Oh, I have a ton, but just too many.
Think of one.
You're not
No, I think
No,
if
sorry.
somebody was
yesterday.
If somebody, what?
Is it harder for somebody to recover from major surgery if you have mast cell activation disorder?
I think that it's a related issue. I'll tell you what it is. If you have a mast cell disease and you have a surgical procedure,
Yeah.
and the surgeon and anesthesiologist doesn't know that you have a mast cell procedure,
Right, because at that time.
you can have a very significant reaction to just the anesthetic. So what we tell our patients that are going to have anything done surgically, you need to be pre-treated with an IV antihistamine, steroids, and aspirin, those 3. And a couple of my patients here are having surgery next week, and what I had to do was talk to their surgeon and anesthesiologist, say 30 minutes before the procedure the patient gets A, B, C.
It's with endoscopy also.
Endoscopy, anything invasive, anything that requires an anesthetic or the stress of surgery.
I believe that protocol is on the TMS website.
We'll be finishing in about 5 minutes, so if you finish asking your questions.
Question?
I don't remember which doctor it was, but somebody mentioned intestinal anaphylaxis. That was the term.
Well, the issue there is anaphylaxis comes in all kinds of grades and shades. You get anaphylaxis from what you inhale. You get anaphylaxis from what you breathe. You get anaphylaxis from what you eat. And having had close to anaphylaxis myself from soft-shell crab, I know the disorder. So people have to be checked in very detailed fashion to see what, if any, foods can be implicated in causing your symptoms. And mast cell patients are entitled to have a number of food intolerances. And as we talked about earlier, it can be intolerant or they can be allergic. It's important to know which is which.
Okay. Thank you. Do you have any opinion on diamine oxidase?
It's used for food intolerances.
Thiamine oxidase?
Yeah, DAO.
No data. No info.
It's used in Europe a lot.
One of the other issues that I have is that people come to see me and they have a whole bunch of homeopathic medicines. They've got, and this one of them that I saw had 60 ingredients in it. 60. I said, does it help you? She says, I think so. I said, well, why don't you find out? Stay on it for 2 weeks, log all your symptoms, come off it for 2 weeks, go on it for 2 weeks, come off for 2 weeks. So get 2 months worth of symptoms, then you'll be able to tell.
You guys have done a great job with, by the way. Great job.
All right. Well, enjoy the rest of the weekend.
Thank you. Most people staying.